السلام عليكم يا جماعة. معكم محمد حجازي, Assistant Professor of Medicine and Bone Marrow Transplant هنا في University of Louisville in Louisville, Kentucky في أمريكا. أنا النهاردة هتكلم معاكم على topic ولو في أي أسئلة عرفوني. عشان احنا share screen. All right. Our topic today is chronic lymphocytic leukemia. We'll talk about its past, its present, and the future practices. Disclosure, مفيش أي conflict of interest. We're going to first talk about epidemiology, pathophysiology, diagnosis and workup, treatment options, and ongoing clinical trials. Epidemiology, so chronic lymphocytic leukemia is the most prevalent type of adult leukemia. However, it's a leukemia of older patients. The median age is about 72 years old, with only 10% less than 50. فأغلب المرضى بتوعنا بيكونوا كبار. Men are affected more than women, so you'll see a 2-to-1 ratio there. There's a possible environmental predisposition. Agent Orange, حاجة استخدموها في حرب فيتنام, and they think that it might have an implication for the development of this leukemia. There is also genetic predisposition, and these are present with about 10% of patients have a first degree or a first degree relative with CLL. This is from the CIARITY database, incidence and mortality, and you can see with the light green, this is the estimated new cases in 2018 last year, about almost 54,000 new diagnoses. However, when you look at the dark green, that's the estimated deaths in 2018. It's 0.3%, so it's not a very deadly disease. It's a disease with excellent prognosis. But what causes chronic lymphocytic leukemia? Simple answer is we don't know. We know, however, that there is clonal chromosomal abnormalities that are detected in approximately 50% of those. So about 50% of our patients will have a genetic signature, something that we feel strongly that is correlating to the development of chronic lymphocytic leukemia. The most common clonal abnormality in this disease is trisomy 12. However, abnormalities affecting chromosome 13, 14, and 11, as well as chromosome 17, are present. Patients with abnormal karyotype have worse prognosis. So the more complex the cytogenetics, the worse the prognosis. However, I had cases with complex karyotype and CLL. I've been watching them because they did not require treatment. They're doing just fine. This is just a look at the blood, at the bone marrow and the development of and the normal hematopoiesis. As you know, the bone marrow the bone marrow is where blood is being made. All these different blood types are made there: red blood cells, white blood cells, and platelets. Amongst the white blood cells is the lymphocytes, the top of that left course right here. Oh, sorry. And that's where, in the lymphocytes, that's where the CLL developed from. To be more specific, it appears from mature B cell lymphocytes, as you see the one circled, that's the mature B cell lymphocytes. Generally, in terms of clinical manifestations of this disease, 40% of those patients are asymptomatic, and they're diagnosed on a routine CBC without any complaints to the primary care provider. However, the most common complaint when they do complain is actually also something vague, just fatigue. They just feel tired. Other symptoms as the disease progresses would be enlarged lymph nodes, symptoms of splenomegaly, like a left upper quadrant fullness, early satiety, they're not finishing their meals, things like that. B symptoms is not a common presentation in chronic lymphocytic leukemia, but it can happen. B symptoms, namely fever, drenching night sweats, or unexplained weight loss. Now, as the chronic lymphocytic leukemia progress, it will infiltrate the bone marrow, and that's when you develop cytopenias. So the patient becomes anemic, thrombocytopenic. You'll start getting symptoms of anemia with easy fatigability, dyspnea on exertion, and with thrombocytopenia, easy bruising as such. Always think of your differential diagnosis. It's not every case with elevated white blood count will be, even if it is lymphocytic predominant, will be CLL. So we have to look for infectious causes, bacterial, don't forget about TB, viral like mononucleosis. There's also other mimickers of CLL. They're not as common, of course. CLL is the most common malignant cause, like B-cell prolymphocytic leukemia or a T-cell phase of lymphoma or a hairy cell leukemia, Waldenstrom macroglobulinemia, as well as large granular lymphocytic leukemia. All these guys can cause phases of significantly elevated lymphocytic predominant leukocytosis. Workup, remember, as a hematologist, we always like to look at the smears. And here's a smear. You see a significant increase of the white blood cells. That's the purple looking ones, the white blood cells. You know, generally speaking, you have one white blood cell in every 1,000 red blood cell, but here you're seeing them way more common than that. And they're all small with a dense nucleus. Not a very aggressive one. But you also see here on the right lower corner, the smudge cells. Those are the cells that basically are, they rupture during the preparation of the smear. And this is also one of the remarks or the findings on peripheral smear for CLL. The diagnosis of chronic lymphocytic leukemia comes to be confirmed with the use of flow cytometry, and you can do that on the peripheral blood. If you do peripheral blood flow cytometry, you're going to look at certain markers because you want to identify the B cell clone, because in order to reach the diagnosis, and we're going to come to talk about it first in a second, in order to reach the diagnosis, you need to actually identify how much of the lymphocytosis is of a similar clone of B cells. And as you see here in the right upper corner of this slide, you see this is a flow cytometry graph. As you see, the CD20 is on the x-axis, and the y-axis has the CD5. And typically CLL is positive on both ends. So the red dots, these are all CD20 positive, CD5 positive B cells, and that's consistent with the phenotype of chronic lymphocytic leukemia. You get your diagnosis with a flow cytometry, but you don't finish your workup by just getting to the diagnosis of chronic lymphocytic leukemia, because it's very important for us to prognosticate for this population, as well as determine therapy based on other findings. So we'll need to do a FISH to look for deletion 17, gain of chromosome 12, deletion of 13q, or deletion of 11. You have to say deletion of 17p specifically is always pointed as the more aggressive disease. Deletion 11q is considered also. The VH gene status, so the IGVH, and that's a molecular test. You need to get the status of that. Is it mutated or unmutated? And we'll talk about why is that important in a second. ZEP70 used to be a common test, a common prognostic marker. However, it's not recommended outside of clinical trial at the current time. Beta-2 microglobulin. We don't need to do any CT scans unless symptoms necessitate. PET-CT scan can be helpful if you're concerned of Richter's transformation, meaning the CLL is transforming into a more aggressive lymphoma, most commonly diffuse large B-cell. Last but not least, bone marrow biopsy and aspirate is not necessary in the in the diagnosis of chronic lymphocytic leukemia. So you don't need the bone marrow biopsy to diagnose it or to even prognosticate or determine therapy. However, if a patient has low blood counts and developing some cytopenias and you want to investigate the infiltration of CLL into the bone marrow, that's fine. You can definitely go for it. Here's the flow cytometry picture, is a little bigger. All right, now the topic of chronic lymphocytic leukemia should also cover the other two terms that are closely related. So chronic lymphocytic leukemia is the presence of lymphocytosis in the blood of a monoclonal population of mature B-cell lymphocytes, more than 5,000. So the count is 5,000. All right. SLL, which is in our mind is considered a synonym to CLL. CLL, SLL, you'll find it everywhere written that way, CLL/SLL. That's when the leukemia is not actually in a leukemic phase most of the time. It's involving the lymph nodes in the spleen and the bone marrow rather than the blood. So it's a monoclonal B-cell lymphoma that is not reaching 5,000 in the peripheral blood. However, it is associated with lymphadenopathies, splenomegaly, or cytopenias. The last term is MBL, and that stands for monoclonal B-cell lymphocytosis. And this is when you don't meet your cutoff for 5,000. So monoclonal population of mature B lymphocytosis, B-cell lymphocytosis, less than 5,000 without adenopathy or any other organ involvement is called its own thing, and it's monoclonal B-cell lymphocytosis. This has the risk of developing chronic lymphocytic leukemia, or CLL, at 1% annually. Staging, Rye staging is on the left. That's what has been done since the 1970s. Dr. Rye came in with this staging, and Benet came after with a very soon after a incorporation of blood counts to also stage. So pretty much Ray it's a stage 0 as well if it's only lymphocytosis and there is no lymph nodes enlargement. Stage 1 is if it is lymphocytosis with enlarged lymph nodes. Stage 2 if it has splenomegaly or hepatomegaly, in addition to enlarged lymph nodes and lymphocytosis. Stage 3 is when the hemoglobin gets affected and become less than 11. And stage 4 is when the platelets gets affected and become less than 100,000. This is the Lugano modification of Ann Arbor staging. So basically, we're using the regular non-Hodgkin's lymphoma staging. When it's one group of adjacent lymph nodes, that's called stage 1. 2 or more nodal groups on the same side of the diaphragm, that's stage 2. Stage 2 bulky is when the size of the lymph nodes is more than 7.5 centimeters. Advanced stages is when it's, stage 3 is when it's above and below the diaphragm, and stage 4 when it is extranodal involvement and it's non-contiguous. So it's not really just an encroachment of some solid organs by a surrounding enlarged lymph nodes. It's a separate involvement. Prognostic markers. So as I mentioned, after you get your flow cytometry and you have reached your diagnosis of chronic lymphocytic leukemia, you get FISH. And the FISH basically gives you 50% of the time a finding. This finding can be favorable, as you see here in the 13q deletion, or unfavorable, as at the top of the list is the 17p deletion. And there's also other findings in between the two. And when I say favorable and unfavorable, it's because of the prognosis and the need for therapy in those patients. And here is two graphs that compared the treatment-free interval for the different mutations. And you can easily notice that the blue on the left graph, on the graph on the left, the blue line, which is the 17p deletion, they don't waste time to require treatment. So almost 50% of those patients will need treatment within 2 years. However, for example, if you look at the 13q deletion, those guys might live for 5 years and they still do not need treatment, and it might even live longer than that. On the other hand, is another curve of in regards to survival, and this curve is remarkable. As you can see, that there is a significant overall survival difference between these different mutations. 17p deletion, you're looking at, of course, you know, this is a disease where the patients live longer. So I'm not talking about anything within a year or two that anybody with CLL from diagnosis would be dead. But even when you compare them over a very long period of time, you will notice that 50% of those patients with a 17p deletion CLL are dead within about 4 years. However, with a 13q deletion, those people might be living 15 years without any compromise to their overall survival from chronic lymphocytic leukemia. And most of the time, they die from unrelated causes, like things that has nothing to do with CLL. So here's other prognostic information. It's just, that's how we look at it. So TP53 is basically another marker for 17p deletion, which is the worst finding. So you do TP53 as a molecular testing as well, and however you do the 17p deletion on your FISH studies, and they are both considered unfavorable. However, IgHV, or the immunoglobulin heavy chain variable region gene mutation, this is more of a, when it's mutated, it's better. So patients do better when they are mutated with IgHV, which, because the mutated IgHV basically gives those cells still the ability, despite their dysfunction, give them still the ability to make immunoglobulins, and they've been noticed to be, when they are mutated, they are more sensitive to chemotherapy. Deletion 17 is resistant to chemotherapy, and strides has been made in improving those patients' outcomes with the use of targeted therapies that we're going to talk about in a little bit. VH mutation, that's the heavy chain mutation. So the B-cell naive lymphocytes, they have unmutated variable region. However, the hypermutation of this area creates those memory B cells, and they make those antibodies with higher affinities to their antigens. So it's better to have that in those patients. CLL progression is dependent on mutation status of the B cells. So unmutated V means that it's an earlier and less mature B cell. Progresses rapidly and has a short survival, just to make it simple, while the mutated ones is more mature, slow progression, long survival. And here is to prove the difference between the variable region of immunoglobulin between the two statuses, mutated and unmutated, and there is a significant difference. As you can see with the dark green, the unmutated heavy chain, always remember we look at the 50%. 50% of them within 100 months, which is less than 10 years, they're dying. However, they might be living double that amount, double that duration of time before they before 50% of the unmutated IGVH develop. Succumb to their disease. Here's a quick case: a 60-year-old Caucasian male with past menopause, hypertension, hyperlipidemia, type 2 diabetes, presented for a routine follow-up with his PCP. Patient had no complaints. Physical exam is unremarkable. Blood count was 15,000. Acute lymphocytic count was 10,000. Hemoglobin was 13. Platelets 250,000. What's the next step in management? Will you check a peripheral smear? Would you send this for flow cytometry? Would you refer to hematology? Would you do bone marrow biopsy? So, I gotta say, the first step would be to get a peripheral smear. That's the easiest to do. But sending for a flow cytometry is not a bad idea either. 60-year-old Caucasian male with past medical history. This is the same patient. Comes in this time. The peripheral smear, you reviewed it. It showed lymphocytosis. The cytoplasm is thin, nucleus is dense and clumped and no nuclei. It's commonly called soccer ball lymphocytes. There's a lot of broken cells, which we call smudge cells. The flow cytometry was done and showed abnormal B cell clone that is CD5 positive, CD23 positive, CD20 dim. What's the next step in management? So now, knowing this, you have a large clone that has achieved they've reached the diagnosis of over 5,000 B cell lymphocytes, monoclonal B cell lymphocytes. So you've reached your diagnosis of chronic lymphocytic leukemia. Now, what do you do next? Would you scan this patient? Would you perform a bone marrow biopsy, or would you start chemotherapy? The correct answer is we need to risk stratify this patient. So we need FISH, cytogenetics, and molecular studies to know which mutations does this patient carry. But most likely, patient does not need any treatment, and active surveillance is the right answer. However, in order to know for the future how long is it going to take for this patient to require a treatment, then we should do that. Now, so 2 years later, the same patient came. After you've been going with active surveillance for all this time, he comes in with fatigue, shortness of breath on exertion. Labs shows his white count has gone up from 15 to 20. His ALC is now 15,000. His hemoglobin is 7.5. That's a drop for this patient. Platelet count, 140,000. And T-belly is 3.2. LDH is 800. What's the underlying process? So this is just to touch base on one of the complications of CLL in this group, which is called autoimmune hemolytic anemia. Autoimmune hemolytic anemia. So autoimmune hemolytic anemia is what led to the drop in this patient's hemoglobin, leading to his bilirubin being total bilirubin is 3.2 with elevation in his LDH. You look at the peripheral smear in the right lower corner, and you see here poikilocytosis and also anisocytosis. You're also seeing some nucleated red blood cells, And if you pay a little more attention, you might find some reticulocytes. So all these are signs that this patient is hemolyzing. Remember that autoimmune hemolytic anemia, you diagnose it with the look of the reticulocyte, haptoglobin direct agglutination test, or Coombs. Autoimmune hemolytic anemia develops in the setting of treatment with fludarabine. So fludarabine, which is one of the chemotherapy that we used to commonly use, not so much now, but we still use it in certain population. In CLL, the fludarabine itself can cause that. So you have to actually pay attention to see which one is causing it. Is it the CLL or is it the treatment for the CLL? ITP can be also development. It's an autoimmune cytopenia. So, however, in this case, you might want to look in your bone marrow. Pure red cell aplasia, which in this situation, you would always look for parvo B19 and a bone marrow evaluation. The treatment for all those is typically, this is a warm autoimmune hemolytic anemia. That's what it is, and steroids is the way to go. If steroid doesn't work or if the patient needs any further treatments, you can use IVIG or Rituxan, and then you can look at all these second, third line, and fourth and fifth line of therapy, including cyclosporin up to splenectomy, or using those topomimetics like eltrombopag or ramaplastin. All right, okay, so that patient you said did not need to be treated? No, this patient needs to be treated for autoimmune hemolytic anemia, and if he responds, you might still continue to monitor their CLL and not have to treat it itself. Okay, so when do you treat chronic lymphocytic leukemia? There is no advantage in treating chronic lymphocytic leukemia until symptoms develop, regardless of its genomic features, unless we have a clinical trial that is putting patients who are asymptomatic without any kind of cytopenias, to the treatment group. There is no evidence that supports that. We should always watch them until they develop it. All right, so now the IWCLL in 2008 came up with these criteria for treating those patients. Primary or relapse, enlarging symptomatic lymph nodes, more than 10 centimeter. That's large lymph nodes, or symptomatic. It doesn't have to be more than 10. If it's causing symptoms, it's big enough to be treated. Enlarging symptomatic spleen. So typically that's a spleen that is more than 6 centimeter below the costal margin. Cytopenias due to CLL, like a hemoglobin less than 11 or platelets less than 100,000. If the patient develops B symptoms, if you could not control the autoimmune hemolytic anemia or ITP, so you treated them and you couldn't control them, then you look into that. Look into treating the CLL itself, and maybe that will decrease the progression too. Will decrease the development of these autoimmune hemolytic anemias. Progressive lymphocytosis with an increase of more than 50% over 2 months period, or lymphocyte doubling time of less than 6 months. And that's a controversial point. Typically, you see a patient comes to you, and if there is a 50% increase, so let's say you saw him, white count was 30,000, they came in 2 months later and the white count is 45,000, you know that this patient is likely going to require treatment very soon. This is not always adopted by hematologists. Some of it is being studied, and most of the time it's up to the discretion of the treating oncologist. All right, so these are the when do we start treatment. These are the treatment options, which is a big list of options. The blue on the left is your old therapies. That is the past. That still occupies a very small population of the present. Fludarabine, bendamustine, pentostatin, cyclophosphamide, chlorambucil. The development of targeted antibodies with the turn of the millennium had a massive magnitude in the treatment of CLL. The appearance of Rituxan, ofatumumab, obinutuzumab, alemtuzumab. All these are targeted therapies. The first three are all directed against CD20. Then we've got even other targets like intracellular targets like ibrutinib, Idelalisib, ABT199, which is venetoclax, along with others. And this is the present. And the future is what lays on all the way to the right lower corner: cellular therapy, CAR T cells, and immunotherapy. All right, CD20 antibodies are a major component of our treatments in CLL. As you see, both Rituxan and obinutuzumab have a similar binding site on the CD20 here on the graph on the right side. To the right, while alpha-2 binds to CD20 at a different site. What happens is it binds, it develops a complement-mediated lysis of those cells. It also stimulates the effector cells, as well as a direct effect. Antibody binding, it just induces anti-proliferative signals, apoptosis, and cell growth inhibition. All right, so now what is the standard? What is the standard in treating those patients with CLL? The standard of in treating CLL depends on the age, as well as the fitness in general, and their genetic mutations. So not every young and fit CLL patient will receive FCR. But if they do not have this deletion 17, maybe fludarabine, cyclophosphamide, and rituximab is the way to go. While bendamustine Rituxan, we know it's not as good as FCR in this population, but it's also an option. You can use fludarabine Rituxan and drop cyclophosphamide. It's not as good, but it's used. Pentostatin, including therapies, as well as obinutuzumab, chlorambucil is another option. And here is the study of FCR versus BR. This was done in patients who were untreated, active CLL without deletion 17, and in good shape. In good shape. They either got FCR, fludarabine, 25 milligrams per meter square, IV, days 1 through 3, cyclophosphamide, 250 milligrams per meter square, days 1 through 3, Rituxan, 575 milligrams per meter square IV on day 1, on day 0 cycle 1, and then you're going for Rituxan 500 IV on day 1 of cycles 2 through 6, and they compared that to bendamustine, which basically similar dose of Rituxan, and just got rid of the fludarabine cyclophosphamide and used bendamustine. Here's the outcome. This is the CLL-10 trial. FCR median progression-free survival was not reached. While it was reached at bendamustine Rituxan at 44.9, almost 45 months. That's statistically significant in the favor of FCR. Overall survival at 2 years were quite similar. There was no difference. Overall response rates were pretty much identical, but higher CRs observed with FCR compared to PR. And when I say CR, complete remission means the disappearance of the clone as well as the resolution of adenopathies, or whatever is the indications that led to that, to the treatment. So in this population, you'd see if you combine complete remission as well as complete remission or complete response with incomplete hematologic recovery, you will see that 47.4% of the FCR population achieved it, while 38% achieved it in the BR arm, with a p-value of 0.03, which is statistically significant. However, if you look at the bottom of the table, overall objective response rate was identical. All right, how about in older or unfit patients without the deletion 17p? Always remember, clinical trials is a great option, is a great place to start. However, if they do not have deletion 17, you can consider chemoimmunotherapy with the use of bendamustine Rituxan, because we know that FCR is quite toxic to older or unfit populations. You need somebody in good shape to tolerate it. However, in older and unfit, bendamustine rituximab maybe has a room, or obinutuzumab rituximab has, obinutuzumab chlorambucil has a room. And here comes ibrutinib, which has been approved in this population as well. And here is the trial comparing obinutuzumab chlorambucil to Rituxan chlorambucil. So it was randomized, it's CLL11 trial, randomized chlorambucil to obinutuzumab chlorambucil as well as Rituxan chlorambucil. And here is the responses. Chlorambucil alone was poor. However, when we use chlorambucil with Rituxan, you had an overall response rate of 65% with CR of 7%. But if you use obinutuzumab instead of rituximab, which both are CD20 antibodies, just to be clear, the response rate improves to 78% overall response and 21% complete responders. We have to state that clearly, and you have to pay attention to that, that in terms of toxicity, obinutuzumab is more toxic than rituximab. It has more infusion reactions, that's a clear one. It also is associated with more infections and cytopenias. This is the curve comparing the two together, looking at the probability of progression-free survival. Obinutuzumab chlorambucil versus rituximab chlorambucil. And you see the median probability of progression-free survival was about a little over 10 months apart between the two. Now, this is the CD20 antibodies in collaboration with chemotherapy. Now, this is a busy diagram, but it actually illustrates to you how much we have added, how many therapies have been added to our toolkit in treating CLL, from surface markers to intracellular cytoplasmic markers, and all of them are either under current clinical investigation or already approved. Ibrutinib, and I'm just going back to this curve. Ibrutinib, you can see it here in the middle, it's inside the cell. It's a Bruton tyrosine kinase inhibitor, so it sits under the BCR receptor on top of the surface, and with its with the inhibition of this, you develop three ways of cell death, and here it is. It inhibits the proliferation and survival. It also inhibits the adhesion, so those lymphocytes are less able to break through the bloodstream and get to the lymphocytes again. So it blocks them from going back to the lymphocytes. And also, and that's another way of modulating its chemotaxis and trafficking, so they don't travel appropriately. And that's why you want to kill them. You don't want them to go and proliferate in various parts of the body. Resonate trial. So this was the first trial studying ibrutinib in relapse refractory CLL population. And this was studied with ibrutinib against ofatumumab. The primary endpoint was a progression-free survival. Progression-free survival here, when you look at Kaplan-Meier curves like this, it's very easy. But you can see that there's a significant difference between the two arms. You can, and this is one of my mentors during my training would tell me, there's something called the rule of thumb. And the rule of thumb is when you are able to look at the diagram and put your thumb between the two curves and it fits, that means this is significant. You don't need a statistician to tell you that, and it's obvious. These two curves are separated very well, that you can actually, without anything, notice that the difference is significant. You can see this is as good as a hazard ratio can be. a hazard ratio of 0.22 is telling you that there is 78% of those patients had a significant benefit of using ibrutinib over ofatumumab. So when using ibrutinib, you have to be familiar with what will go once you start the drug, because it's a great drug. It works very well. However, it has some points that you need to pay attention to, so you don't think that the disease is progressing and you don't interrupt treatment. So the pattern of response between the lymphocyte, the lymphocytic count, or the CBC, and the leukocytosis in general, as well as the lymph node size. So on the left-hand side, you see a graph where the lymphocytes, after the initiation of ibrutinib, they go up. So this patient, for instance, started at a baseline, this group of patients started at a baseline of around 50,000 lymphocytes. It went to as high as over 350,000 before, within 2 months, before it declined back within 6 months. So the first 6 months of treatment using ibrutinib, which is an oral pill that they can take on a daily basis, and you should tell them that, remember, don't worry about the white blood cell count. The white blood cell count is going to at least double over the coming couple of months, but within 6 months it will come down and everything should be fine. But how do you pay attention then to the disease? Then you need to look at the lymph nodes. If this patient had lymphadenopathy, and this is here the curve showing you in the same population how the lymph node size, the change from baseline in this diameter, has declined significantly, as despite the rise in the white blood cells. And we believe this is because the ibrutinib blocks the white blood cells from going back into the lymph node. So it's a one-way track. The lymphocytes are just going outside of the lymph node. And based on that, the white count goes up, but soon they die, and you achieve your goal of reduction of all these findings that is associated with chronic lymphocytic leukemia. And this is a patient that on the left is before starting ibrutinib. This was a refractory CLL with 11q deletion. At the left is a patient before starting ibrutinib, and she did not have any kind of plastic surgery to get rid of a double chin or anything like that. She actually just took a pill a day, and here you go, boom, completely. The neck is very different. You can even tell how the necklace is fitting around her neck. This is trying to tell you that ofatumumab is not at all as good as ibrutinib in all groups, no matter what you're looking at, no matter which stage. Ibrutinib is way better. However, you have to pay attention to the side effects of ibrutinib. So ibrutinib can cause cytopenias, so you need to keep an eye for the CBC. It can cause GI symptoms like diarrhea. It also, which is not mentioned here, but it's important because this is a finding that came after this drug was actually used in humans, because it wasn't known to do it in animal trials. It's atrial fibrillation. So atrial fibrillation has been linked to ibrutinib, so we have to pay attention to that. Now, this is pretty much ibrutinib. Now, the next in line, the next very, very interesting target is BCL2 inhibitor, venetoclax. And venetoclax is a unique small molecule that goes and binds to BCL2. BCL2 is an anti-apoptotic marker that basically signals proliferation and makes the cell, allows the cancer cell to evade apoptosis by sequestering pro-apoptotic proteins. But when you inhibit the BCL2 with the use of venetoclax, those pro-apoptotic proteins gather around the mitochondria within the cytoplasm and lead to activation of the capsases and cancer cell death. And venetoclax monotherapy in the use of in relapsed refractory CLL, SLL. So this is initial study with showing a high affinity for BCL2, evaluated patients who both had deletion 17 or fludarabine refractory, and the response rate was significant. Overall response rate was over 80% on both arms, with 12% complete remissions in deletion 17 versus 22% remission in fludarabine refractory CLL. And this is the data from the Morano clinical trial stating that, and that, you know, small percentage of the patients also needed to discontinue the drug. Idelalisib. Idelalisib is another target in the toolkit in treating chronic lymphocytic leukemias. This is a phase 3 trial using Idela with Rituxan for previously treated patients with CLL. They stratified them between the different risk groups, either deletion 17p/TP53 mutation or IGVH mutation status, to either Idelalisib plus Rituxan versus Rituxan alone plus placebo. The clinical endpoints were primary endpoints was progression-free survival, and events were assumed as disease progression or death. And here is the difference. Idela plus Rituxan is significantly more efficacious compared to rituximab placebo, with a hazard ratio of 0.15. That's, again, as good as it gets. Again, Idelalisib can cause the same issue in terms of the absolute lymphocyte count and tumor burden. But on this curve, you see both curves. The blue line is the absolute lymphocyte count. It goes up in the first couple of months, and then within 6 months, it goes down. However, the lymph nodes are actively shrinking throughout from the get-go, from the start. Here's a patient. She started on the left before treating with Idelalisib with significant adenopathies. She got Idelalisib, and here she is. Again, comparing Idelalisib Rituxan to Rituxan placebo, of course, Idelalisib Rituxan won on all levels, regardless of the risk, 17p deletion or not, it works. However, Idelalisib is a quite toxic, and that's why it sits in the third line of targeted therapies in our book. So common side effects are fever, fatigue, nausea, transaminitis, the liver enzymes go off, severe infections can happen, cytopenias can happen, as well as GI symptoms and diarrhea. Now, ibrutinib. So ibrutinib, after being approved for a relapsed refractory CLL, they now said, we're going to go for the kill. We're going to go to the first line therapy to get approved in CLL, all comers. So this is the RESONATE-2 trial. RESONATE-2 trial included treatment-naive CLL/SLL with active disease, but they said, okay, we're going to look at the elderly, 65 or older, for patients 65 to 69 comorbidity that may preclude them from FCR. Deletion 17p were excluded, so they did not even, they know they are very effective in 17p, so they didn't want to keep those guys in a comparison because they know that ibrutinib will win it. And patients on warfarin, because how ibrutinib can increase the risk of bleeding, so they have excluded those. And they compared chlorambucil, which is criticized wildly as an option, because nobody uses chlorambucil a single agent in treating CLL, but they compared that to ibrutinib on the standard dosing. That was a phase 3 open label multi-center international study with a primary endpoint is progression-free survival. And here is another application for the rule of thumb. Now you can easily fit your thumb between those two curves and know very well that you're not going to touch either curve. And this tells you that this is statistically significant. And again, the response rates and progression-free survival is extremely high, even on a longer follow-up. All right. So this is the current practices and the past. So chemotherapies with CD20 antibodies was our past. Our present is more in the small molecules and the use of ibrutinib, venetoclax, and Idelalisib. But what's next? So in the works, hopefully soon will be approved next generation ibrutinib. It's called acalabrutinib. It is more specific in inhibiting BTK, which is the first on this table, and this is something called the this is something that they use to differentiate the ability of those inhibitors to affect different targets. And if you look at the ibrutinib column, it actually is able to inhibit quite a bit of all these off-targets markers that you generally might not want at all in the treatment of the CLL specifically. However, if you look at the acalabrutinib, the dose that will get you to inhibit BTK, which is your goal, is much, much lower than the dose that can inhibit anyone. TEC, EGFR, ITK, JAK3, you need a much higher dose in order to inhibit those. While for ibrutinib, the dose that is therapeutic to affect the BTK is also able to affect a whole bunch of others, if not very close. And this is the response in terms of lymphadenopathy with the use of CT scans, the use of acalabrutinib in the CLL, and you see here the gray is stable disease, which is only one patient. Partial responders are a ton of them. And then a partial remission was, in addition to the resolution with lymphocytosis, is the rest. All right. How about mixing it all together? Ibrutinib, venetoclax, and obinutuzumab. How does it work? You get the obinutuzumab started early. You get the ibrutinib started the next cycle. And then you get the venetoclax thirdly added on the third line. So let me just confirm my, yeah. So based on this, this is a trial to combine target therapies that we know that they work independently, that maybe if we mix them together, we'll be able to achieve a better response. All right. And this is on a prelim results. Look at it. Complete remission. So this was a small number of patients. You see, we're only talking about like 12 patients total. Achieved a complete remission in 2 out of those 12. Partial response in 10. Partial remission in 10. And progressive disease, none. Now, when you look at the colors, these are when you're comparing peripheral blood, minimal residual disease assessment to bone marrow. And our goal is to maybe achieving more and more our goal is to eradicate this clone from the bone marrow if we can. And you see here the very, very light tan color. That's the peripheral blood negative, bone marrow negative on both curves. And that's significant. That's significant with the use of just targeted therapy, non-chemotherapy. I like it. And then there is the TAP Clarity trial, which basically mixed ibrutinib with venetoclax. Is an impressive early results in CLL. It's a phase 1/2 clinical trial, population relapse within 3 years of FCR or ABR. Had 17p deletion and has failed at least one line of therapy where to be recruited. After 8 weeks of ibrutinib monotherapy, you add venetoclax. You start at 10 milligrams a day with weekly escalations to 50, to 20, 50, 100, 200, and to a final dose of 400. There was no TLS, tumor lysis syndrome, in the first 3 patients, starting at 10 milligrams a day of venetoclax. So all subsequent patients began venetoclax at 20 milligrams per day. Primary endpoint, MRD eradication defined as less than 1 CLL cell in 10 to the power of 4 assessed by an 8-color flow, multicolor flow cytometry in the marrow after 12 months of ibrutinib venetoclax. And the key secondary endpoints were MRD eradication from the marrow after 6 and 24 months of ibrutinib venetoclax, as well as safety, of course, because of phase 1 into 2. Results. 25 patients reached their 8 months follow-up, 6 months of ibrutinib venetoclax together, marrow and CT scan assessments. All 25 patients has responded. 100% overall response rate, a very unapologetic response. However, 60% of those has achieved complete remission and complete remission with incomplete count recovery. All of the remaining PRs due to small volume lymphadenopathy at the site of larger lymph nodes at baseline. So sometimes you cannot completely get rid of your lymph nodes. Conclusions: combination of ibrutinib venetoclax is well tolerated in relapsed refractory CLL. Only 2 out of 4 patients experienced biochemical TLS to date. All 25 patients reaching initial response rate assessment after 6 months of ibrutinib venetoclax had responded. 60% in CR, 28% achieved an MRD negative remission in the marrow. These early results suggest a potent synergy between ibrutinib and venetoclax. And here comes the Brits. So FLAIR trial is currently recruiting. Group 1 gets ibrutinib, Group 2 gets ibrutinib and rituximab, Group 3 gets ibrutinib and venetoclax, and Group 4 gets FCR, the old standard. This is currently recruiting, so we don't want to talk much about it. Now there is the IFCR, is in America and everywhere, iPhone, iPad, iPod. Now we have IFCR as frontline therapy for younger CLL patients. So this is mixing the old standard FCR with the new standard ibrutinib in one line. And FCR prolongs disease-free survival for many CLL patients with mutated IGHV. However, patients with unmutated IGHV typically have less durable responses. CR with bone marrow, minimal residual disease negative, so they cannot detect it at all. Historically, FCR can get you 20% of those patients. Given the excellent efficacy and tolerability of the frontline ibrutinib across CLL risk types, investigator-initiated multi-center phase 2 study of ibrutinib plus FCR as a frontline treatment for young, fit CLL patients was initiated. Primary endpoint was the rate of CR with negative bone marrow for any residual disease at 2 months after FCR. Secondary endpoints included response rates, PFS, and safety tolerability. They used 420 milligrams daily monotherapy, given 7 days. Then you start the combination FCR for up to 6 cycles. Responders continued on ibrutinib maintenance for at least 2 years. A recent study amendment allowed accrual of 50 additional patients who discontinue ibrutinib if bone marrow MRD negative. After 2 years of maintenance, and can restart ibrutinib if they recur. Antimicrobial prophylaxis and growth factor, of course, were needed. populations were younger patients who meet the initial indication for treatment. ECOG tumor status is 1 or less, with good organ function. Criteria are evaluated. MRD assessed by 4-color flow cytometry and also by adaptive clonal sequencing. Results. Data cutoff, July of 2017. Almost 50 patients has been accrued, including 35 patients in the original cohort and 14 patients in the new expansion cohort, whom safety and efficacy data are not yet available. All those 50 patients, median age at enrollment were 55 years, had these are the characteristics for them. The baseline blood counts, as you know, the white count was high, so median was 87,000. Hemoglobin, platelet counts, and all these baseline characteristics. Efficacy. Overall response rate, 100%. But what's more impressive is the 63% complete remissions. And then you look at the rate of complete remission with bone marrow negative MRD. That's the primary endpoint. 37%. 37% were MRD negative, which is an increase, with a best rate that increased with post-FCR ibrutinib maintenance to 57%, so even higher. Best rates of bone marrow negativity by flow, irrespective of the IWCLL response, was 83%, including 77% of patients in the PR. With a median follow-up of 20 months, all patients are alive and 86% remain on treatment. 2 bone marrow negative patients electing to discontinue ibrutinib, 2 patients who discontinued ibrutinib due to toxicity, and 1 patient with deletion 17 who achieved MRD negative post PR and elected to pursue allogeneic stem cell transplant. Conclusions: IFCR reduced deep responses in a relatively high-risk group of previously untreated young CLL patients, with 57% achieving CR and 83% achieving bone marrow minimal residual disease negativity, significantly higher than 20% rates seen historically with FCR alone. Low rates of hematologic and infectious toxicities may be due to mandatory growth factor and antimicrobial prophylaxis. Updated results on the ibrutinib discontinuation cohort will be presented in the future. Now, last but not least, and just I'll finish with this, is CAR-T therapy. So to those who are not familiar with CAR-T therapy stands for chimeric antigen receptor T cells. So these are T cells that we collect from the patient. We take them to the lab. You get a vector that is carrying a marker that gets basically transduced and expressed once it's incorporated in the T cell DNA on the surface as a detector / killer to those T cells, to those B lymphocytes. You give them some lymphodepletion to the patient, and then you give him those 2 T cells back. And now you have trained / educated those cells to do the job. You monitor the patients, scans, marrows, peripheral blood. Remember, this is a line that got quite a bit of toxicity that we have to pay attention for. Cytokine release syndrome. We have to pay attention for neurotoxicity. And these are the different generations. There's now a 4th generation as well. So you're basically carrying a marker on top that is detecting those with a co-stimulatory domain that is very important, we believe now, on which domain you are using, either it's a 4-1BB or a CD28. And we're working on getting those more and more advanced with each step of development. And this was published by Carl June, who is the first to actually study this type of therapy in humans. In New England Journal of Medicine, chimeric antigen receptor modified T cells in chronic lymphocytic leukemia. And you can see here before therapy, all these lymph nodes, enlarged lymph nodes, how they have shrunk with the therapy. You can see the lymph node sides on the axial as well as the coronal, where the lymph nodes has shrunk significantly and almost disappeared. There's a few anti-CD19 CAR therapy for CLL already been studied and reported between University of Pennsylvania, the NCI, Memorial Sloan Kettering, and more centers come in. The challenges with FCR is feasibility. It's very expensive. One dose of these cells is worth an average about $400,000 to $500,000 per dose. You need physicians who are trained to deal with this. There is relapse in the form of CD19 negative, so you're basically selecting for those CD19 negative cells because you're eradicating them. Because you're eradicating the CD19 positive, but also there's some relapses that are CD19 positive and you cannot reuse the same CAR. Defining the best CAR, because there's different viruses, there's different vectors, there's different co-stimulatory domain, and all these things are still in the works. In summary, CLL is the most common leukemia, often asymptomatic and not treatment needed, no treatment needed. On diagnosis with time to treatment depends on the prognostic markers. Elderly and frail patients treated with targeted therapy like ibrutinib, then venetoclax, then Idelalisib. Young patients treated with chemoimmunotherapy like FCR, BR, then ibrutinib, as long as they don't have those worse prognostic markers for which you would then go ahead and start the targeted therapies right away. And then clinical trials, a combination of targeted therapies and CAR T cell therapy are ongoing. Let me just tell you, this is what I use as my diagram. This is the diagram that I use to actually treat my CLL patients. So you get a patient, untreated CLL patient, if they have TP53 or 17p deletion, if it is mutated, ibrutinib right away. If they are TP53 intact, then I look at the IGHV mutation. If it is mutated, that is the better risk. If they are young and fit, I would give them FCR, chemotherapy. If they are old and frail, give them ibrutinib versus obinutuzumab or chlorambucil. You can pick. While if they are unmutated IGVH, and those are the people who don't as good respond to FCR or to chemotherapy, so the young and fit, I'll give ibrutinib personally. And if they are older and frail, I'll continue to give ibrutinib also. So with this, that's the end of it. And you can reach me at my email, Higazy@louisville.edu, if you have any questions. And that's it.